Mr. Cal Santos, and I'm a student nurse practitioner. I'll be doing your assessment today. This video will be uploaded on YouTube for the course. Is that okay?
Yes.
Okay. What brings you into the clinic today?
I used to be a smoker. I just want to get my lungs checked.
Okay, good. So I'm gonna go ahead and inspect your. I'm gonna be inspecting for Carson, which is the color for cyanosis. AP ratio normal is 2:1. I'm inspecting both anteriorly and posteriorly for his breathing. Checking the rate of breathing, checking for symmetry of chest rise, making sure that's normal and even. I'm checking his effort of breathing, no use of accessory muscles, no nasal flaring. That's good. And also I'm going to be checking for nail clubbing, checking lips and fingers. Okay, so checking his breathing, both anteriorly and posteriorly, inspecting that everything is good. Now I'm going to be palpating. I'm going to check for respiratory excursion. So I'm going to have you sit at the edge of the bed that way. And I'm going to place my hands to the 10th rib, this 10th rib, with my thumbs by his 10th rib, and then I'm laterally going to span my fingers across. I'm going to ask the patient to take a deep breath in, and when he does that, I'm making sure that everything rises symmetrically, and take a deep breath out. Good, good. Okay, so you can come back and take a seat right here. After palpating for respiratory excursion, I'm going to be checking for tactile fremitus. So I'm going to take the palmar aspect of my hand, place it along the intercostal spaces, and ask him to say 99. And I'm checking for for vibration. Normal finding is a vibration. So go ahead, say 99.
99.
Good.
99.
Going in a ladder fashion.
99.
Good.
99.
Good.
99.
Good.
99.
Good.
99.
Good.
99.
Okay, good.
99.
Good.
99.
Okay, good. And then I'm also going to be checking posteriorly.
99.
Good.
99. 99.
Good.
99. 99. 99. 99. 99.
Okay, good. So I'll be doing that anteriorly and posteriorly, checking for tactile fremitus. Now I'm going to be checking for costal chondral tenderness. I'm going to be palpating in the intercostal spaces, checking for tenderness. So Thomas, I'm going to go ahead and palpate. I'm going to with my fingers, I'm going to touch you right, and you let me know if there's any pain. Is there any pain or tenderness?
No.
No, good. And I'm also going to be making sure I compare both sides, as I palpate, checking for tenderness. I'm going to be doing that anteriorly and posteriorly as well. So making sure that I'm able to compare both sides of the lung fields and the intercostal spaces. And after palpating, I'm going to be percussing. And the technique to the percussing is taking my middle finger, placing it by the intercostal spaces, and tapping it with my other middle finger. I'm checking for dullness and resonance. I'm going to be percussing and listening for dullness and resonance. And same thing, going on a ladder fashion. I'm going to do that both anteriorly and posteriorly, making sure that I also check the right and left lateral aspects. And then also same to the back. And same thing, checking for dullness and resonance and the anteriorly, posteriorly in the intercostal spaces. So normal findings should be, there should be some dullness, there should be some dullness to the left aspect because of the organ. And then next one, after I check for costal chondral tenderness, I'm going to be, after I percuss anteriorly, posteriorly, making sure I get the lateral aspects as well. I'm going to be checking for the diaphragmatic movement. So this is basically, it maps out the diaphragm movement during full inspiration and expiration. So I'm going to be percussing down to his intercostal spaces, noting where it changes from resonance to dullness. So I'm going to have you sit at the edge of the bed again. Good. And you're going to go ahead and take a deep breath. And okay. Oh, sorry. One more time. So right about here is where it's more dull. Okay, and exhale out. And same thing. And hold. And then I'm going to be noting where it's more resonant. And okay, so right about here is the diaphragmatic movement, and you can breathe and then face this way. So the diaphragmatic excursion or movement is normal finding is about 3 to 6 centimeter. After I percuss for the diaphragmatic excursion, I'm gonna be auscultating. So I'm gonna grab my stethoscope. So same thing how I did the palpation and the percussion. I'm gonna make sure I go in a ladder fashion, comparing both sides anteriorly and posteriorly. So I'm gonna ask you to take a deep breath every time I move the stethoscope, okay? Good. Okay, deep breath. Good. Deep breath. Deep breath. Deep breath. Deep breath. Good. And then I'm also going to be checking for making sure I check for the lateral aspect. Good. Okay, deep breath. Good. And then now I'm going to check your back so you can. So I'm going to be checking his posterior aspect, going on a ladder fashion as well. So when I check the anterior, I also made sure that I check for the apex of the lung, which is at the sternal end of the first rib. So now I'm going to do the posterior, going in a ladder fashion. Take a deep breath. Comes good. Making sure I check for any adventitious sounds, checking for breath sounds as well, that it's not diminished or increased in any of the lung areas. Good. So far all lung sounds is clear to auscultate bilaterally. Good. Good. Okay. A few more deep breaths. And same thing for the back. I'm going to make sure that I assess his lateral aspects. Good. And last one. Good. You can take a seat. So, just a quick recap. I made sure that I inspect, palpate, percuss, and auscultate, making sure that I palpate for respiratory excursion, tactile fremitus, as well as coastal chondral tenderness, and then percussing, make sure that I percuss in a ladder fashion, comparing both sides, the right side and the left side, as well as posterior and anteriorly, noting the dullness and resonance aspects as well. And then I made sure that I percuss for diaphragmatic excursion, noting where it changes during inspiration from resonance to dullness, and then dullness to resonance at expiration, and normal is 3 to 6 centimeters. But otherwise, that was a normal and healthy exam. No abnormal findings noted. His color is good. AP ratio is 2 to 1, which is a normal finding as well. His rate of breathing, regular, even respirations, no difficulty breathing, no dyspnea, and it has symmetrical chest rises, symmetrical chest excursions as well. No effort of breathing is easy, and no nail clubbing. So I'm going to be double checking. So, and then also checking his toes. That ends our lung exam respiratory assessment. Thank you.